So you can tell that our program has had a losing streak since you've graduated, Mike. We're so glad to have you back. And thanks for coming back to the New York section to lecture us today. We look forward to hearing from you. So you can go ahead and get started.
Great. Thanks, Dr. Al-Alao. I appreciate the invitation also from Dr. Cooper and Dr. Small. This is really fantastic that you've organized all of this. And it's great to see that all the New York programs are participating. And hopefully this will be kind of one of the lasting legacies of this whole crisis, the teamwork and coming together aspect of everything. So I know y'all are working very hard up in New York. So I wish you grace and courage as you're continuing to fight the battle up there as we deal with this crisis. I will issue a correction there. So I actually lost the New York section debate, but then redeemed myself at the national debate at the AUA that year. So I was sort of, 1-1.
So the losing streak is longer than I realized.
The losing streak is longer than you realize, exactly. Okay, so getting into things. So we're going to talk about prostate cancer and some preventative strategies. And a lot of this is somewhat beyond the scope of what's routinely discussed. And a lot of the information here is born from the idea of patients asking when you see them who may have family history or who may be concerned, what can they do to prevent prostate cancer? And I often tell them there's no medicine that we can give to prevent this, but there are certain dietary and sort of holistic strategies that we can employ. And certainly this is not meant to replace normal screening, diagnosis and treatment, but as an adjunctive, or as we refer to it, complementary approach, that can be very beneficial for patients and allow them to sort of be proactive and take charge about ensuring their health and well-being. So moving on, for prostate cancer is the most common solid malignancy in men. There's estimated to be 190,000 cases in 2020. It's the second leading cause of cancer death, and you see in the cartoon below. Interestingly, prostate cancer has actually become more lethal than colon cancer. You see, this is from 2017, where prostate cancer was actually the third most lethal malignancy, and now it's surpassed colorectal cancer. Whether this is due to decreased screening for a time because of the USPSTF recommendations in the past is not clear, but it is substantially prevalent in society and warrants investigation. So there are, for the residents, there are several risk factors for prostate cancer, one of which is family history. Having a brother with prostate cancer puts you at a higher risk than having a father. You see the relative risks listed there. African-American race, about 1 in 5 or 6 African-American men will be diagnosed with prostate cancer. Obesity has been shown to be associated with higher risk prostate cancer, possibly in the setting of, kind of the hypogonadal state that can be induced by excessive adipose tissue. And although it may not be more prevalent in obese men, certain obese men who may have underlying hypogonadism, if prostate cancer develops, it's thought to be probably more aggressive. Advanced age, there's been autopsy studies showing that about 80% of men in their 80s who have died from other causes, like car accidents, strokes, heart attacks, things like that, about 80% of them will have trace amounts of prostate cancer on autopsy. Various environmental factors, and that kind of underlies what we're going to be talking about here. Dietary impact. Also, tobacco use has been associated with higher risk prostate cancer. Agent Orange exposure is interesting. For those residents that work at the VA, you will see this, and it actually is a covered event by the government because it is Agent Orange is a known carcinogen. So they will basically, service workers who have service members who have been exposed to Agent Orange will have all their expenses paid by the government if they develop cancer. So genetic factors are becoming more and more understood in their role in prostate cancer oncogenesis. Two main classes of genes that have been shown to be mutated that are important to know are the DNA damage repair genes, those involved in homologous recombination, such as BRCA1, BRCA2. These are involved in DNA double-strand break repair and are associated with not only breast cancer, as you may imagine, the BRCA1 and 2, but also prostate and ovarian cancer. They've been shown to be mutated in anywhere between 2 and 12% of prostate cancer, more advanced prostate cancer, and certainly metastatic castration-resistant prostate cancer tends to have a higher incidence of these mutations, but they can occur in localized prostate cancer as well. BRCA2 has a higher relative risk. You see about 9 on the slide compared to 2 for BRCA1. There's an ongoing study called IMPACT that we'll look at in a second. And the NCCN 2020 guidelines actually recommend germline testing for patients who are locally advanced in terms of having node positivity or metastatic disease. DNA mismatch repair genes, which you traditionally associate with Lynch syndrome and upper tract urothelial carcinoma, have been shown to be mutated in advanced prostate cancer. These are associated with microsatellite instability, and there may be a role for immuno-oncology therapy like pembrolizumab, and with multiple lines of therapy failing for these metastatic castration-resistant patients. So I want to bring this up because there's also been investigation into the prevalence of these mutations. As I mentioned, up to 12% of DNA damage repair mutations are found in metastatic castration-resistant prostate cancer. Localized disease is around 5%. You see down here, low-risk disease, probably only 2%, and up to 6% in high-risk disease, as evidenced by the TCGA, the Cancer Genome Atlas Project. Higher Gleason score is also associated. This is just going through, basically some of the breakdown of these mutations. Suffice to say that this can happen. So it's now recommended cancer patients be tested for germline mutations, but also a smattering of localized prostate cancer patients. So any prostate cancer patient who's diagnosed before the age of 50. The NCCN 2020 guidelines not only recommend testing for node positive or metastatic patients, but also high-risk patients, very high-risk patients. Any prostate cancer patient, or like on Oncotype DX, should be considered for genetic testing as well. That's not as widespread, but it is kind of food for thought. For people who have BRCA1 and BRCA2 mutations, this is currently being looked at in a prospective way in Europe with something called the IMPACT trial. Identification of men with a genetic predisposition to prostate cancer, targeted screening in men at higher genetic risk, and controls. So the idea is that BRCA1 and BRCA2 carriers have been shown potentially to have a higher incidence of prostate cancer and more aggressive disease. Although there is longer follow-up needed in that trial, which is currently accruing, preliminary evidence suggests that although the incidence between non-BRCA patients and those who have the genetic mutation is about the same, the BRCA1 and 2 mutation carriers actually had more aggressive disease. So they were more likely to be intermediate or high risk. So, where do we go from here? What do we do with this information, right? We know these predisposing factors, the family history, African-American race. What do we do with this information? Well, obviously, we initiate screening. It's recommended by the AUA, for review for the residents. Screening should be undertaken for men at normal risk, meaning who are not of African-American ancestry and have no family history, from age 55 to 69. We don't do screening for anyone with less than 10 years life expectancy. You can use various Social Security life expectancy calculators or the Memorial Sloan Kettering risk calculator for life expectancy. Screening interval should be every 2 years or so, men of average risk, and earlier screening is recommended for those at higher risk. So those with family history, African Americans, and those with an inherited susceptibility mutation. Recommended to start screening between the age of 40 and 45, depending on whether you follow the AUA or the American Cancer Society. But these efforts are aimed at detection, right? We're detecting the disease. Is there anything we can do to prevent them? So I see a fair number of patients who are DNA damage repair mutation carriers. We have a multidisciplinary genetics clinic down at GW, and we're often seeing these patients, and we screen them, but they want to know, is there anything that we can do to be proactive? Like, is this a ticking time bomb? Is there something that they can institute that will help them and will reduce their risk, or is it just an inevitability? I think the IMPACT trial is going to look into that a little bit. So this gets into the realm of preventative measures. What can we do, right? I mentioned before that there are no medications that we can give to prevent prostate cancer. This has actually been looked at, previously. So we'll get into that, and then I'll talk about some of the work that's been done with traditional Chinese medicine, and also incorporation of Mediterranean diet. And again, some of the evidence is a little bit equivocal and not definitive, but at the same time, it allows patients to be proactive, and can be instituted at various levels, meaning, for just general prevention for the general population, for dietary changes and a holistic approach to prostate cancer prevention. For men who have maybe had a biopsy and been diagnosed with high-grade PIN or ASAP, atypical small lacunar proliferation, as a way of prevention. Men on active surveillance for low-grade prostate cancer, Gleason 6, for example, or even favorable intermediate risk, low volume Gleason 7. So there's various arenas where you can employ these techniques, and again, helps patients to feel sort of more in control. One of the reasons for progression to treatment on active surveillance is this notion, what we term patient anxiety, right? So I think allowing them to be a little more in control can help to alleviate some of that anxiety and reduces risk of progression to treatment because of that factor. So in terms of chemoprophylaxis, that is using medication to prevent prostate cancer development, there's been two kind of seminal studies that have been done. For the residents, this is more of historic interest. And these focus on using the 5-alpha reductase inhibitors, finasteride and or dutasteride, as a way of preventing prostate cancer because of the way that they work to reduce dihydrotestosterone levels, which is much more potent, probably about 7 to 10 times more potent for the androgen receptor binding affinity. So these have been looked at in the past for their role in reducing prostate cancer incidence. So to talk about the prostate cancer prevention trial, this came out in 2003. There was 18,000 men who were basically randomized to two groups. So it was a placebo-controlled, double-blind randomized trial. Group 1 got finasteride, Group 2 got placebo. They were followed for 7 years and then had a biopsy. It was found that overall, about 15% of a placebo group developed prostate cancer. One interesting finding from the study was how PSA relates to prostate cancer. So, for the residents, you may have read about various PSA ranges being associated with statistical risk of prostate cancer. And it's true that, you can tell patients, PSA is not a binary test. It's not either positive or negative. It just puts you on a risk spectrum of how likely we are to find cancer. And as you see on the slide, even men with PSA less than 2, 10% of them develop prostate cancer, even with a PSA less than 2. So the majority don't have it, but it is possible. So this is where these ranges came from, the prostate cancer prevention trial. And sort of interest is the fact that these ranges have been employed in risk calculators to determine a man's risk of prostate cancer. It's been retooled to incorporate free PSA along with race, age, family history, digital rectal exam, and whether they've had a prior biopsy. These prediction tools are more of historical interest, simply because we have better tools now, serum-based biomarkers for prediction of prostate cancer risk. Y'all might have heard about the PHI score or the 4K score. Without getting into them too much, these have kind of supplanted just those risk calculators because they give a sense not only of the prediction of prostate cancer, but of high-grade prostate cancer, which is what we're more concerned about these days. And as a shout out to Dr. McKiernan, the other biomarkers that are currently employed are urine-based biomarkers such as the ExoDx to look at someone's risk of prostate cancer. So my reason for getting into this was just because of the initial prostate cancer prevention trial. This is where those ranges of likelihood of having prostate cancer based on PSA came from, which have been now replaced with some of these more sensitive biomarkers to look for high-grade disease. So back to the prostate cancer prevention trial. So it was seen that finasteride actually decreased the incidence of low-grade prostate cancer by about 40%. However, it was reported initially that it increased the incidence of high-grade prostate cancer by about 27%. And we didn't have a mechanistic explanation for why that might be. But if you see in the cartoon down on the right, we thought that that was due to sampling bias, where before the finasteride, if patients already had a high-grade cancer, it was more likely to sort of miss the cancer based on your traditional extended sextant biopsy scheme. But after finasteride, when the prostate shrinks by about 30%, just a random biopsy was probably more likely to find the cancer by virtue of the fact that the prostate was now smaller. The updated series published by Ian Thompson's group in 2013 decreased that a little bit, but still substantiated that there was an increased risk of high-grade prostate cancer in the finasteride treated group by about 17%. They did fortunately also report that the mortality overall was no difference between the finasteride group and the placebo group. Another trial that looked at this was the randomized trial called REDUCE, which looked at dutasteride for men who had a negative biopsy. This came out in 2010 by Dr. Andriol's group. Again, placebo-controlled, double-blind, dutasteride versus placebo, followed for 4 years. And patients were biopsied at years 2 and 4. And they found similarly that dutasteride reduced the incidence of prostate cancer by 23%, also reduced the incidence of high-grade PIN and ASAP. However, there was an increased incidence at biopsies done near 4 of Gleason 8 to 10 prostate cancer. Again, possibly because of the sampling bias with the smaller prostate. So the FDA looked at this information and concluded that there was, although modest, an increased incidence, an absolute increased incidence of Gleason 8 to 10 prostate cancer with the finasteride dutasteride groups, less than a percent, but it contributed to the FDA not approving these medications for chemo prevention. So this is sort of why we don't give these medications routinely to prevent prostate cancer or for patients who have high-grade PIN or ASAP. The similar overall mortality rate was investigated a little bit further in a retrospective study out of the UK, where they were also able to report that there was no difference in incidence of prostate cancer-specific mortality for people who took 5-alpha reductase inhibitors versus people who did not. There's some limitations to this because they only track the prescription if it was prescribed by a primary care doctor as opposed to a specialist. But I mean, it's reassuring that the people who are on these medications for other reasons, and the principal reason we give 5-alpha reductase inhibitors is for BPH associated LUTs, that it's probably still safe. So seeing these slides, you should not immediately call up all your patients who are on finasteride and tell them to stop, or people taking Propecia. But certainly, these medications are not to be used for prostate cancer prevention without, thorough discussion with the patients. The role of these medications for patients who have already been diagnosed with prostate cancer and are on active surveillance has also been explored as what we would term a tertiary chemoprevention. So primary chemoprevention would be, you haven't been diagnosed with anything yet, you don't want to get it. Secondary chemoprevention would be you're diagnosed with high-grade PIN or ASAP, and you want to prevent progression of prostate cancer. And tertiary chemoprevention would be you have a low-grade prostate cancer and you want to prevent progression or Gleason upgrading to higher-grade disease. So the REDEEM trial was a randomized trial, multi-institutional, 65 centers in North America, took about 300 men with low volume, low risk prostate cancer, and randomized them to dutasteride versus placebo. And they did per protocol biopsies at 18 months and 36 months. Men were followed for around 3 years, and they looked at rates of progression. Of note, they defined progression not only as upgrading to Gleason 4 or higher, but also volume upstaging rather, having 4 or more cores positive or more than 50% of one core. So it's sort of a compound definition. Whenever you're looking at clinical, you're looking at studies, you want to kind of get into the weeds of how they're reporting, because oftentimes we'll do this compound endpoint, which may not be as clinically meaningful. So they were able to show that the dutasteride arm delayed incidence of progression by about 10%. You see the Kaplan-Meier curve here, where the placebo group had a higher incidence of progression than the dutasteride group. Looking into the weeds here about how that progression kind of played out, we see that the majority had to do with volume progression, meaning the dutasteride group was found to sort of have less incidence of 4 or more cores involved. The difference of more than 50% of any one core was kind of the same, and the upgrading to Gleason 4 was about the same as well. So it seems like that difference is more a volume-based progression than actually Gleason upgrading. They did also report that there was a higher incidence of no cancer on subsequent biopsy for the dutasteride group compared to the placebo group. And they also sort of reassured the reader that the incidence of adverse events were statistically similar, although you do see a higher incidence of the side effects that are typically associated with the 5-alpha reductase inhibitors, such as gynecomastia, mastodynia, decreased libido, and ejaculatory disorders. So again, this is sort of food for thought, nothing definitive, and this is basically of historic interest in sort of explaining why we don't see these medications in the AUA and NCCN guidelines. I mean, it has been looked at, but hasn't panned out. So, pharmaceuticals for prevention of prostate cancer, hasn't really led to any kind of substantial change in clinical practice. So where does that leave us? Where does that leave the patient who has a BRCA1 mutation who says, doc, what can, am I a ticking time bomb? What can you do to help me? So this is where we get into the role of complementary and alternative medicine, such as Chinese traditional medicine and using the Mediterranean diet. So complementary and alternative medicine is actually sort of more prevalent than we may think, and often pursued by patients sort of in secret. And we'll see they don't always tell their doctors about what they're doing. And there can be adverse effects of these medications, which we'll discover. There was a study called the Prostate Cancer Therapy Selection Study, which looked at men's decision-making after a diagnosis of localized prostate cancer. And they basically did surveys of which men were using complementary and alternative medicine. And it was reported that over 50% of men pursued some kind of complementary and alternative medicine. Most of them were sort of mind-body modalities with exercise and wellness, meditation, as well as biologically based treatments such as vitamins and other minerals and other supplements. To substantiate that finding, there's been several studies done out of Canada, the UK, and Sweden. So it's been reported that prostate cancer patients are more likely to use complementary and alternative medicine than healthy control subjects in Sweden. About 30 to 39% of Canadian patients who are diagnosed with prostate cancer have used complementary and alternative medicine. One study from 2003 cited saw palmetto, vitamin E, and selenium as 3 of the most common supplements people are using. The reasons being to boost their immune system and prevent recurrence. The interesting thing is actually this study was done before the report of the SELECT trial, which looked at vitamin E and selenium and actually reported a higher incidence of prostate cancer in the vitamin E group, which was mitigated a little bit by selenium, but the selenium caused an increased risk of diabetes. So it's of note that that came out before SELECT. Also, people have used lycopene, and then a study out of the UK showed that 25% of prostate cancer patients were pursuing a low-fat diet, various vitamins, and lycopene as well, again, for boosting the immune system and to improve their quality of life. What about patients who are kind of special populations? About 30% of men who have family history of prostate cancer have been reported to be using various supplements for prostate health or chemo prevention, such as selenium, green tea, and saw palmetto. And this has also been looked at in cancer survivors, and vitamin and mineral use has been reported between a quarter and a third of patients. Interestingly, in this study, actually, it showed that prostate cancer patients sort of use the least supplements. And the reasons for that may be multifactorial, and maybe lack of understanding from the patient standpoint, lack of understanding from the provider, the urologist standpoint, failure to plug the patient into proper survivorship, or simply because some of these measures are not definitive and the evidence is, somewhat, conclusive evidence is somewhat lacking. So, what do we tell patients, or what do I tell patients in terms of dietary preventative measures? So this is from a slide that I used at the NBC Health Expo a couple years ago, to make it sort of very vivid. The Mediterranean diet. Certain things that I highlight here will kind of go into the evidence for them, sort of in a stepwise way. Foods that are good are on the left. These are the unsaturated fats, like olive oil, omega-3 fatty acids that come from fish, lycopene, which is found in cooked tomato products, like tomato juice, tomato sauce, also green tea, which is a potent antioxidant. Soy products have phytoestrogen compounds, which can essentially serve as negative growth factors for prostate cells and prostate cancer cells. I tell men that, the soy or the phytoestrogen concentrations are not enough to be like feminizing. It's not going to change their behavior or their appearance, but can serve as these negative growth factor. And we'll look at some of the in vitro studies that have been done. Fiber and flax seed can be effective because of the lignin phytoestrogen components. Also cruciferous vegetables. And foods that have been implicated to be bad are there on the right. So things like red meat and processed meats, milk and dairy, especially whole fat dairy products. And we'll get into that a little bit, as well as saturated fats from fried foods and desserts. Now, like I said, some of the evidence for these things are equivocal, but at the same time, it allows men to be more proactive, probably has general overlap with well-being, health, and especially cardiovascular health. So, the Mediterranean diet has been shown to reduce the incidence of heart attacks and strokes. So you're sort of, killing two birds with one stone, as it were, promoting not only prostate health, but cardiac health, and helping out your primary care colleagues. There is a huge encyclopedic biorepository of all of this information and how complementary and alternative medicine has been investigated and intersects with cancer on the National Cancer Institute website, where it looks at nutrition and dietary supplements. The website is below. I advise you to look. I mean, it really gets into the weeds of the different arenas where these things have been studied. Arenas meaning, are these in vitro studies, with cell line cultures or cell lines in the petri dish? Are these animal studies, mouse model studies, or are these human studies? And within human studies, are these, big prospective or even retrospective population-based studies where it's hard to kind of derive definitive conclusions? Or are these interventions, for people who may have been diagnosed with prostate cancer or have high-grade PIN or ASAP? So, there's various arenas where this evidence is circulating, and sometimes it doesn't always translate. So, we'll talk about, a couple caveats when we're interpreting all these things. Again, it's hard to find definitive evidence, but at the same time, these dietary changes are often beneficial and have little downside. So a couple things to keep in mind before we get into the evidence here for each of these components of the nutritional program that I tell patients about. The majority of these things have been studied in vitro and mouse model studies. They may not necessarily translate to clinical significance in humans and are hard to study sort of in a controlled way. In vitro studies often involve cell lines that have been immortalized after having been derived from sentinel patients. So it's almost like the HeLa cells, for breast cancer. There's LN cap cells that have been derived from a lymph node metastasis and are actually androgen sensitive. There's something called VCAP cells, which have been derived by a vertebral met and are immortalized and are androgen insensitive. There's also PC3 cells, which are an androgen insensitive immortalized cell lines. A lot of the residents, don't focus on this, the kind of microbiology aspect of, how prostate cancer is studied, being so clinical. So it's very important to understand that, the mouse model and cell line studies of therapeutics against prostate cancer, obviously preclinical research is very fundamental to getting these drugs pushed through the pathway. And there's, an enormous amount of research that goes into it that often, the residents, sort of don't pay attention to because it's not within our scope. So to give some context for how these things are studied. Human studies are largely population-based. They're, big prospective cohorts, such as the NHANES database. There's a dietary lifestyle database from the AARP. The methodology of these studies is also a little bit limited. They often rely on patient-reported questionnaires and food frequency questionnaires that often ask about your dietary habits over a certain specified period of time. That's usually a pretty long period of time. I mean, sometimes it's 12 months, and so you're asking someone to remember what they ate over the last year, or even 6 months, which is sort of a tall order. Obviously, these are subject to reporting bias, recall bias. Patients might not remember. They may report that they eat more healthy than they actually do because they want to sort of look like they're on top of things. Also, there may be a bias introduced by people who don't respond to the survey. And the other thing is that the conclusions of these studies are limited in what they can show us. So they can demonstrate associations, but it's difficult to prove causality. So that's something that I tell my patients as well. It's difficult to fully control for confounders. There are statistical ways to do that in multivariable regression, but oftentimes patients who maybe have poor dietary or less healthy, I should say, dietary choices may also have other risk factors that put them at risk for cancer, such as like smoking use, higher BMI, less physical activity, lower socioeconomic status. And those things have been borne out in studies as well. So there are other confounders that it's difficult to completely control for. The other thing is that complementary alternative medicine formulations or doses or preparations are not standardized. So different companies have different amounts. The amount that's beneficial varies depending on the study, and also these things are not regulated by the FDA. Certainly, if they're contaminated, they can be recalled, but it's hard to sort of police what's going on. Okay, so with that as a disclaimer, where does all this come from about the influence of diet or nutrition on incidence of prostate cancer? So a lot of the evidence comes from basically like migration studies with people coming from other geographic locations to the U.S. and being sort of exposed to the Western diet and how that changes their risk for cancer. Certainly, African-American men have a higher incidence of prostate cancer, which is not necessarily the same as African men. And this has also been looked at with Asian populations that come to the U.S., where the incidence of cancer in Asian Americans is higher, or prostate cancer specifically is higher than in China, Japan, over in Asia. So looking specifically, there's been a couple studies that have looked at this. There was a case control study in Australia where it looked at a Western diet and showed a higher risk of prostate cancer development with red or processed meats, fried fish, chips, and high-fat milk, and white bread, sort of all the things that are indulgent here in the U.S. And also, it's been looked at in China in urban centers with the Westernization of the diet over time. The urban incidence of prostate cancer has actually increased substantially and has more than doubled. So again, this is not a smoking gun causative factor, but it is an interesting association and definitely has prompted further investigation into this area. So looking at red meat as a potentially negative impact on prostate cancer, there's been several case control and cohort studies that have suggested an association, but again, this may be tenuous. In fact, the World Cancer Research Fund and the American Institute for Cancer Research in 2014 reported that epidemiologic and mechanistic data for red and processed meats and prostate cancer are limited and insufficient to make a conclusion in relation to prostate cancer risk. However, there are several mechanisms that underlie why there might be this association. High temperature cooking and grilling releases heterocyclic amines and polycyclic aromatic hydrocarbons, which are known animal carcinogens. Also, N-nitrosyl compounds, or NOCs, are formed endogenously from the cooking of red meat or from the preservatives added to meats like nitrates and nitrites. Heme iron also can produce endogenous NOC compounds, and any iron source can catalyze the formation of free radicals that can damage DNA. And then when the DNA goes to repair itself, you have the potential for introducing mutations with mismatch between the nucleotides that can propagate oncogenesis and tumorigenesis later on. So looking at one particular study about the impact of red meat, which they defined as pork or beef, white meat being turkey or chicken, came from the National Institute for Health AARP Diet and Health Study that looked at 175,000 men, and their measures were meat consumption, heme iron, and nitrite composition. They looked at the type of meat consumed, also the cooking method, such as barbecuing or grilling, and they estimated mutagenic activity, which is sort of neat. There's this thing called the National Cancer Institute CHARD database, which basically looks at sort of the mutagenic potential of various compounds, and they just multiplied the weight of the food that people reported eating, like in grams, by this like mutation factor, essentially, to give an estimate of mutagenic activity, which is sort of interesting. They followed men for 9 years, and then they basically were comparing the highest to lowest quintile of red and processed meat intake. Some of these dietary-based studies have very limited variance between the highest and lowest kind of groups that they're measuring. Here, that wasn't the case, so it seemed it was valid that the highest quintile had much more substantial meat intake than the lowest. So they found that about 6% of men developed prostate cancer, and then 11% of those men had advanced prostate cancer, either locally advanced, node metastatic, or node regional node met positive or metastatic. And then you see the breakdown there of the hazard ratios for developing prostate cancer. Red meat contributed, processed meats, and also higher heme iron content, and barbecue or grilled meat. Advanced prostate cancer was also influenced by these things, as well as nitrite and nitrate composition. There was no association with fatal prostate cancer, however. And again, this study actually kind of substantiated some of these confounding factors. Although they controlled for them in their analysis, they did find that increased red meat intake was associated with being less educated, being a current smoker, having a higher BMI, and being less physically active. So again, in these type of studies, it's hard to dissociate those other potential confounding factors, but it is kind of thought-provoking. There has been a subsequent systematic review and meta-analysis in 2015 that looked at 19 different cohort studies and again investigated red and processed meats, heme iron, and this heterocyclic ambient exposure. They did meta-regression to try to identify a dose-response relationship, and their outcomes were, again, prostate cancer, advanced prostate cancer, and fatal prostate cancer. They looked at summary relative risk estimates, or SSRE, which they found to be significant only for the processed meat exposure. There was no dose response seen in their meta-regression, and the study said that there may be publication bias with studies. So you see the forest plot below on the right that shows the cumulative effect of the processed meats, whereas the red meat group on the left didn't show any consistent association. So getting into some of the phytonutrients and therapeutics, so traditional Chinese medicine has been explored and has been around for eons. There was of historic interest a compound called PC-Spes, which was made up of 8 different herbs. You see, some that are familiar: ginseng, licorice, saw palmetto, chrysanthemum, also some mushrooms. And there were multiple in vitro studies done showing that this collection of compounds had an impact on cell line growth and also androgen-insensitive cell line growth. This was actually developed as a shout out to New York back, I think, in the 1990s by a traditional Chinese medicine doctor in China, who had special proficiency in herbal medicine, in combination or in collaboration with a chemist at New York Medical College in Valhalla. So they developed this compound. Again, was shown to be effective in cell lines. Some human studies showed that it decreased PSA levels and also testosterone levels. However, many of these men who were taking this, and actually speaking to some of the more senior members of my practice, they remember a lot of patients were on this, and then they unfortunately started developing DVTs, and so it prompted investigation into what was actually in this compound, that was proprietary, and they found that there was actually contamination with an oral form of estrogen called diethylstilbestrol, as well as Coumadin and Xanax. So it was voluntarily recalled in 2002, so it hasn't been around for 20 years, and it's not currently legally available in the U.S. There are some replacements, but nothing purported to be the original composition. So it's interesting that each of these compounds sort of in isolation has been looked at, and that initially it showed promise, but whether it was because of these medicinal herbs or because of the the DES contamination is not known, and it hasn't really been subsequently studied. So getting back into the prostate cancer diet that I tell my patients about, we'll look a little bit at the evidence and kind of go through, in a linear way through each of these things and say, okay, what's the evidence for each of these things, with the caveats that I mentioned kept in mind. So in terms of fish, the omega-3 fatty acids have been shown to be beneficial for cardiovascular health. There's been several studies. One meta-analysis of 12 case control and cohort studies showed that men who had high fish intake had 63% less death from prostate cancer. The Harvard Health Professional Study looked at eating fish more than 3 times a week reduced your risk of prostate cancer, metastatic prostate cancer. However, there was a Swedish study that showed after following men for 30 years, this one showed that also no fish consumption was associated with 2 to 3 higher time of prostate cancer risk. So, food for thought there. Green tea is a catechin. It's a potent antioxidant. It's been shown to suppress androgen receptor signaling and may inhibit cell proliferation. It actually acts systemically. And listed there is, the caffeine content per cup. One thing I'll tell patients who are motivated to take this is to buy decaffeinated green tea pills as a supplement, as opposed to having to drink the green tea, which can be caffeinated. And certainly, as we know, many men are suffering from BPH or have lower urinary tract symptoms, so we want to minimize caffeine intake. So some of the decaffeinated pills is one way to get around that. Multiple studies have been done in vitro and also mouse model studies. Interestingly, some of the murine studies that have been done, there's this type of mouse that's been genetically engineered called the tramp mouse that develops prostate cancer. And mice treated for 24 weeks with green tea extract had about a 40% risk reduction in prostate tumor development after about 8 months. So these mice that were genetically engineered to develop prostate cancer, when treated with green tea, actually developed less prostate cancer, and there was also 70% less metastatic spread. This has been looked at in humans for men with high-grade PIN. A couple randomized trials out of Italy. One published in 2006 showed giving green tea extract 600 milligrams per day reduced the incidence of prostate cancer from 53% to 11% in men who had been diagnosed with high-grade PIN. Although there were some limitations in this study, although there were 60 men initially, only 20 patients were included at the 2-year follow-up. So the conclusions are not as robust. And in fact, a subsequent study done in 2015 on men with high-grade PIN in a similar dose of green tea didn't show any risk reduction in incidence of prostate cancer after a year of follow-up. So it's controversial. We don't know the methodology as well, whether this was multifocal PIN, whether it was unifocal PIN, so that may have an impact as well, the volume of these atypical cells. So it's still sort of equivocal, but probably has a low side effect profile. Pomegranate juice has also been looked at, given its very potent antioxidant properties. It's anti-proliferative, also has been shown to increase apoptosis. There's been a few human trials in the arena of reducing PSA doubling time for men who have recurred after being treated for prostate cancer. So this is especially kind of fertile ground. It's known that PSA doubling time at the time of recurrence impacts prostate cancer mortality and also influences our decision to treat these patients. You may imagine that if patients are recurring after having been treated, they may be elderly, they may be in their 70s, they have competing risks of mortality. So we don't necessarily automatically treat all men who have a rising PSA after having been treated. If the PSA doubling time is long, then we may watch. Most of that data comes out of what we call the pound data out of Johns Hopkins, where they were checking patients' PSAs after having had surgery, but weren't reacting to them. They were just basically tracking the PSA, and they would only intervene with systemic androgen deprivation therapy at the time of metastasis. And that's where we get the sort of average or mean time natural history of prostate cancer survival for those who have recurrence after surgery. It was about 8 years. And then after initiation of hormone therapy at the time of metastasis, patients lived for another about 5 years. That was influenced by when the recurrence happened, the original Gleason score, and most importantly, the PSA doubling time. So, for the residents, the point here is, that recurrent prostate cancer, you get a sense of PSA doubling time to see what the potential mortality is, and can use that information to guide treatment. So can we prolong that PSA doubling time? Is there a way to use, phytochemicals and nutrition to do that? This has been looked at with pomegranate juice. There was a phase 2 study, obviously with no control group, but a phase 2 study for patients looking at their doubling time, intervening with 8 ounces of pomegranate juice a day, and then looking at PSA doubling time afterward. And it showed that the PSA doubling time increased. So this prompted a phase 3 trial, which wasn't quite as favorable, looking at 180 men where they had 3 groups: pomegranate liquid extract versus juice versus placebo for 12 months. The PSA at the time of entry was 1.2, so relatively low. They followed them up for about a year and a half. They did find that the PSA doubling time actually increased for both the placebo and the juice groups. And this prompted further investigation into a certain polymorphism that exists that impacts sort of response to antioxidant therapy. So it's been found that people who have a certain genotype mutation, like the alanine residue in this enzyme manganese superoxide dismutase, are more prone to oxidative stress because of the way that this sort of isoform of the enzyme produces hydrogen peroxide that can lead to more free radical damage. So there's actually, very interesting, and also in the vein of like personalized and precision medicine, they found that people who had this mutation were more sensitive to the pomegranate extract, sort of were more likely to benefit from the antioxidant properties of the pomegranate. So you see here that the the placebo patients didn't really have a change. The placebo mutation carrier patients didn't really have a change in their doubling time, but those who did have the mutation were sensitive to the extract and also the pomegranate juice. So we don't routinely test for this mutation, but because of the potential benefit, in the low side effect profile, again, this can be recommended for patients to prolong their PSA doubling time. Again, in the vein of patients potentially having lower urinary tract symptoms, especially if they've had radiation and are now recurring, pomegranate juice is very tart, so can exacerbate urinary symptoms. So you just want to make sure patients are watching out for this. Flaxseed has been looked at. It has been shown to lower blood pressure and cholesterol. It contains phytoestrogens that serve as negative growth factors for prostate cancer. There was one randomized study with men who were under suspicion for having prostate cancer because of an elevated PSA, and were given flaxseed, and it showed that on their biopsy they actually had lower Ki proliferation rates in the cells. There's also been animal studies that have shown inhibition on prostate cancer growth. Usually I tell patients that they can add the flaxseed to like their cereal in the morning, or Greek yogurt. Yogurt obviously is dairy, but as we'll see, the fermented dairy products I think have less negative association with cancer, probably because of their promotion of good intestinal microbiota that is increasingly being understood to be linked to positive effects against cancer development. So dairy compounds, they do contain bioactive compounds such as insulin-like growth factor, which has been linked to prostate cancer development. The high saturated fat content of certain dairy has been shown to increase testosterone levels, which is a known growth factor for prostate and prostate cancer. The World Cancer Research Fund has looked into this, as well as the American Institute for Cancer Research, and they said that there was an association in 15 to 21 studies investigated that showed an association between dairy intake and prostate cancer. Some of these studies that were included the NHANES trial and the AARP study that we mentioned before. So these are kind of big population-based studies. The role of insulin-like growth factor has been looked at in various meta-analyses. One from 2008 showed about a 40% increased risk of prostate cancer for men who had the highest quintile of insulin-like growth factor. And then another meta-analysis showed a similar association, looking at 172 studies, and showed an association between insulin-like growth factor and increased prostate cancer risk. Looking further at the role of dairy, the prostate, lung, colorectal, and ovarian cancer study, the PLCO study, which was admittedly subject to a lot of contamination, also looked at the association of dairy intake and prostate cancer. This study that I found had a very good follow-up of about 11 years and looked into the weeds of the type of dairy that was consumed and what its association was. So they stratified it by fat content, also whether it was fermented or not, like yogurt, the frequency, the portion size, and how it was consumed. They found that there was no association except for regular fat dairy for advanced prostate cancer was about a 37% increased risk. So again, maybe somewhat equivocal, but there is mechanistic explanation for this as well. Looking at the role of fat, I tell patients that there's good fats, there's bad fats. Unsaturated fats are the good fats. So those are those that you get from olive oil, nuts, avocados, or vegetables. Also, polyunsaturated fat comes from fish with the omega-3 fatty acids, flaxseed, and walnuts. Saturated fat is found in meat, and also trans fats are found in baked goods and fried foods. So those are to be avoided. There was an interesting intervention that came out of UCLA a little while ago, where they took men, drew their blood at baseline, and then had them engage in a dietary and exercise intervention where they give them a low-fat diet, high fiber, and encourage them to exercise, and then redrew their blood. They spun down the serum and basically exposed LN-CAP cell line, prostate cancer cell lines to the serum, and they looked at sort of what happened. So this is when the serum was given to the LN-CAP cells, and it showed that the cancer cells grew. After the intervention, they gave it, and the cancer cells didn't grow as much. Here, when they gave insulin-like growth factor 1, which is a known growth factor for prostate cancer, despite the dietary and exercise intervention, the cells still grew. So this is basically corroborating the role of the insulin-like growth factor. Moving on to lycopene. So lycopene is found in tomato products. It gives certain foods its red pigment, and although the evidence is limited, there is mechanistic explanation for why this might be effective. It does inhibit insulin-like growth factor 1, has been shown to suppress VEGF as well. And it's been studied for many indications such as prevention, pre-prostatectomy, for men on active surveillance. These are small studies, however, and the results are inconsistent, but there are few toxicities, and the FDA basically says that they're generally regarded as safe. The World Cancer Research Fund said in 2007 that lycopene-containing foods probably protect against prostate cancer, although in 2014 they changed their tune and said that there's really no conclusion possible because of the limited evidence. So some studies have looked at this in men with high-grade PIN. One in 2005 said that there was a PSA decline in these men, less prostate cancer diagnosed. Another study showed that there was basically no impact. And then a meta-analysis in 2015 looked at dietary lycopene, the circulating concentration of it, and also looked for a dose-response association. And they were able to find that there was a linear association between higher consumption of lycopene, and lower incidence of prostate cancer. So soy products, as I mentioned, have phytoestrogens in them. The structure is similar to estradiol, and they can bind to the estrogen receptors. Also can be used for reduction of cholesterol. There's mixed evidence for use with pre-prostatectomy, such as during active surveillance or for biochemical recurrence, but it has been shown to mitigate side effects such as urinary, GI, and sexual side effects as a result of radiation, and can reduce hot flashes for men on ADT. The dose usually associated with this is 40 grams of isolated soy protein. However, to be aware, high oxalate is a problem with soy products, so patients who have a predisposition to kidney stones, I have to be careful. So I'm sort of getting toward the end here, so I can kind of rush through. One thing I'll mention is, we're trying to use these things for chemo prevention, but we don't want to, create chemo promotion, where some of these, dietary supplements can actually cause a worsening of the disease state. Many patients will take vitamins and actually not report them to their provider because they're thought to be just, benign, that are innocent, that they don't cause anything or any problems because you can get them over the counter. One thing to report here is that initially there was something called the alpha-tocopherol beta-carotene study looking at male smokers with vitamin E and beta-carotene to see what the impact on diagnosis of lung cancer risk was. And they found that there was actually a lower incidence of prostate cancer in the vitamin E arm. This then prompted the SELECT trial, where they actually gave a 5-time higher dose of vitamin E than in the ATBC study. And actually they found that there was a higher incidence of prostate cancer by 17% that was mitigated by selenium, meaning when they gave us the selenium as well, there wasn't the higher incidence. So there also has been reports of adverse impact of zinc, and also adverse impact of vitamin D. And there was another study that looked at giving folic acid to try to prevent colorectal adenomas, and there was about a 3-time higher incidence in this population of prostate cancer. The relationship of folic acid with the cancer was thought to be relatively multifactorial or complex, but these are not benign things, and should definitely be discussed with the patients. So, these are all not benign. Green tea has vitamin K, which can obviously impact on coumadin. As I mentioned, soy has a fair amount of oxalate that can impact kidney stones. Fox Chase Cancer Center actually reported that about 50% of patients will initiate complementary and alternative medicine without discussing it. And that PCAT study that we mentioned before showed that about 43% of patients discussed CAM use with their provider, so the majority do not. Some of the popularly available supplements like Super Beta Prostate, Prostagenics, they contain phytoestrogens. These are mostly used for like BPH and urinary symptoms, not necessarily for prostate cancer. And I'll finish up here with just pointing out, so if you type in prostate cancer diet to clinicaltrials.gov, you get 55 studies looking at this. So it's although the evidence is limited, it's very currently it's very thought-provoking, and I think, like I said, offers a way for patients to be proactive about taking a role in their prevention, or those on active surveillance, perhaps mitigating the risk of progression. A couple notable studies at the University of Maryland is use of a ketogenic diet for active surveillance. Also at UCLA, they're using a carbohydrate-restricted diet for active surveillance. And then UCLA is also using a low-fat diet along with fish oil to help prevent progression on active surveillance. So it's a very fertile ground for studies, and I think there's more important things to come. So in conclusion here, so risk-adapted screening reduces prostate cancer mortality. Genetic testing is important even among localized prostate cancer patients, such as those with high-risk disease. As we discussed, chemo prevention is not FDA approved. Traditional Chinese medicine and the Mediterranean diet have shown promise for a holistic approach to prostate cancer prevention and treatment, but there's much more work to be done and is being done. So sort of what I tell patients is to minimize red and processed meats, fatty foods, and dairy, and to try to incorporate some of the supplements like lycopene, green tea, soy, and flax. So some of the future directions might look at the use of these dietary interventions for patients with inherited DNA damage repair or mismatch repair mutations, or looking at dietary intervention We looked at for PSA doubling time, for the pomegranate use, but it would be interesting to see if patients who had, you do a prostatectomy, they have T3A or T3B disease or node positivity, to put them on, a dietary intervention and see if this postpones or prevents, biochemical recurrence, given that this population is at such high risk.
Thanks, Mike.
Great.
That was outstanding. We're at the 9 o'clock hour now, but just two questions for you. The first came from Justin Gregg from MD Anderson. He says, great talk. Wants to know what your thoughts are on the meal study and difficulties in showing diet-related benefits in low-risk prostate cancer.
Oh, that's a good question. I'm not familiar with that. So I'll have to look into it. I mean, it's interesting. It's a sort of a heterogeneous population as well. I mean, it would be interesting to see whether, the different, basically prevention for people who haven't been diagnosed versus high-grade PIN or ASAP. But I'll have to look into that.
Another question, is there a handout or standard dietary recommendations that you give all of your patients who are interested in CAM and have a diagnosis of prostate cancer?
Yeah, there is. It's basically compiled from, some of this evidence that I presented in the talk, as well as use of one of the AUA updates. I think that came out in 2015 or so. So I kind of repurposed that into a handout. It basically focuses on those things that I mentioned with the, reduction of processed meats and red meat, incorporation of fish and chicken as opposed to red meat, getting protein from nuts, and, like fish as opposed to red meat, trying to cut out butter and dairy and using more olive oil.
The Mediterranean diet.
The Mediterranean diet, yep.
How would you advise someone taking male-enhancing supplements or even testosterone supplements while also taking saw palmetto?
It's interesting. I mean, if it's like an over-the-counter supplement, I'm not sure about the efficacy of those things. But I mean, if someone's on testosterone for hypogonadism, certainly that's one of the, it's a growth factor, so it can promote BPH and BPH-related symptoms. The question is, is the testosterone acting systemically and creating more like vitality and vigor and, maybe increasing libido, and the saw palmetto sort of mitigating some of the growth factor effects on the BPH? I don't know that this has been studied, and I actually don't know the answer to that. But it's, a possible way, I guess, to get the systemic effects of the testosterone with possibly blocking, the effects on the prostate. But like I said, I don't know if that's been studied.
And last question, is there any update about statin and the prevention of prostate cancer?
I think there have, I haven't looked into it recently. There are mechanistic explanations for why that might be. I think using the like PI3 kinase pathway, kind of blocking that pathway, and also work with metformin. But I guess to be completely honest, I haven't looked into it recently, and I don't know at what kind of stage it's at in terms of doing more organized trials.
Well, thank you so much, Dr. Whalen. The overwhelming comments we're getting here is that it was a great talk, very informative. We were so happy to have you as part of the Empire series. We want to remind everyone that we're going to be having another series of lectures tomorrow, starting at 7 o'clock. It's going to focus on the management of